As you know, we are currently experiencing a pediatric mental health crisis, with youth mental health concerns and unmet needs higher than ever. K-12 schools are a critical setting to provide mental and behavioral health services. School-based services meet students where they spend most of their time, can help support prevention, and can make behavioral health services more accessible and less stigmatizing. Many PolicyLab faculty, including myself, conduct research in the school mental health space. For example, developing and evaluating interventions that can be delivered within schools and alongside educators. PolicyLab is also interested in advancing the discussion about how to finance, sustain, and evaluate school-based behavioral health services through payment reform, greater cross-sector partnerships, and ongoing support and evaluation. Several of us have collaborated on a recently released white paper regarding funding and sustaining comprehensive school-based behavioral health services. We are thrilled to have this wonderful group with us today to reflect on innovations related to behavioral health planning, delivery, and funding in K-12 schools and policy levers for sustainability. So before we get started with the session, we'd like to have a little bit more of a sense of who's in the room with us. Could you please raise your hand if you are coming from primarily a research background? From the education sector? As a healthcare provider? From the policy sector? Or from another background that I didn't just name? Okay, thank you. So today's session will start off with individual presentations from our three panelists, and then a question and answer time at the end. We ask that attendees save questions until that question and answer period. I would now like to introduce our moderator, who will introduce the speakers, and will also moderate the question and answer period. We are so pleased to have with us today Dr. Samantha Reaves as our moderator. Dr. Reaves is a clinical community psychologist and a faculty member at the National Center for School Mental Health at the University of Maryland. She strives to integrate her research and clinical work to improve outcomes for children. Her research interests lie at the intersection of mental health and education, and she often investigates how school or family factors influence student outcomes in underserved communities. Dr. Reaves, thank you so much for being here today, and I will hand it over to you to introduce our first speaker.
Thank you, Gwen. Nice to see everyone. I feel like we should be doing some other type of performance up here in this beautiful space, a little ballet. But first, I wanted to introduce Dr. Louise Fink. She is a director of the Home and Hospital Health Services for Baltimore City Schools, and she will be speaking today about lessons learned from successful expanded school mental behavioral health initiative in Baltimore City Schools.
Some of us need to have logistics explained. Good afternoon. It's really special to be here today. For a number of reasons. Number one, being at Children's Hospital of Philadelphia is a really special privilege. There is a, okay, thank you. Some of us are challenged. And it is really special to be here today. There's no more important topic to discuss than our children. Our country has no greater resource than our children. The partnership between the mental health communities and our schools is an essential ingredient in education. A sound mind and a sound body is critical for learning. Too many of our students experience mental health challenges that impact their ability to learn and benefit from the educational system. Often access to funding is a challenge that creates barriers to providing optimal implementation of mental health services in schools. Now I'm going to be challenged here. Let's see if I can get this to do. And why mental health in schools? Very good reason, because that's where the children are. Agencies require an appointment, parents missing time from work, students missing time from school, outcomes, out of school, missed appointments, no service, ongoing issues. In school, students present, minimal disruption, ongoing impact. Why mental health services in schools? Because that's where the children are. When the notorious bank robber Willie Sutton was asked why he robs banks, his response was very immediate, because that's where the money is. Where are America's children most of the day? They are in school. If we need to impact students, we need to reach them in school. When they require an appointment with a physician or a therapist at an office, it means making an appointment, leaving school, parents missing work, missing educational time, and then repeating the same scenario for the next appointment. 4 appointments with a therapist may mean missing the equivalent of 2 days of instructional time. 4 with an in-school therapist may mean 2 hours of time. The comparison intensifies the need for therapists to be in school. Go. Emotional, behavioral, and social difficulties diminish the ability of children to benefit from the educational program. Attendance is impacted by mental health programs. Data from the 2012 Adolescent Behavior and Experiences Survey suggests that disruptions and consequences related to the COVID-19 pandemic have impacted the mental health and well-being of youth. School closures, family issues, and social isolation have contributed to an increase of mental health issues and concerns in school-age children. Over the years, Baltimore City Schools has developed a lot of partnership to make this work. We happen to be a seasoned, I guess I'm standing here looking like a seasoned educator, but we happen to be a seasoned program because we started our collaborative program back in 1989, which is a long time ago. But over the years, we had discovered that people were, A, not keeping appointments, B, there were a lot of agencies that they had programs, but they had very few slots, and C, that our kids weren't getting what they needed. So we started a program with the Behavioral Health System Baltimore with a block grant and with community mental health agencies, and we ended up with a public health services waiver, which the Medicaid people gave us so they could provide services and bill for them in school. We got private grants from foundations, and we ended using blended funding, which a lot of people can't stand, one of my favorite things, which is nobody gets indirect money. I hate to see money that you've worked so hard to raise going into indirect funds. The only indirect fund Baltimore City gets from that is I don't get to sleep late. So our partnership initiation started with Baltimore City Schools and the Baltimore City Health Department. And yes, we were partners right from the beginning. Anything that we did with them, and we worked with them, and we made sure that we understood each other. Our population is poverty-stricken. Over 85% of our students qualify for free lunch, which means that along with completing for the free lunch and the free breakfast and the free dinner we give them, they are also Medicaid and CHIP eligible, which means that there is a source of funding out there if we just go to it. And our initial model focused on mental health only. We began with 1 school, and then we expanded to 14 schools. Just one of the things that I was listening to as I discussed this morning, I have not figured out any way to make things happen all at once. I find that if you start with a pilot and it works and you go ahead further, it might take a year or 2 longer to get where you want to go, but you have sound ground. So then we added behavioral health, Baltimore Mental Health System, which is the behavioral health system of Baltimore. We added prevention funding through our first 6th grade initiative. We added funding for the Baltimore Substance Abuse Initiative, and we added money for early child mental health. All of those things enabled us to expand our programs and do more with what we were going to be able to do. In 1996, one of the things that happened was we were able to collaborate with Medicaid, and there was a waiver which created a public behavioral health system and allowed mental health services to be provided in the schools, but still billed as part of the mental health agency, which is very significant. One of the things that happens is you can want to do all the good in the world, but like really stuck with where the money is, everybody needs to have the money available. So if you want to bill for services in school, you have to have that mechanism in paid. And Medicaid Maryland was really very cooperative. So what happened was that outpatient mental health clinics could bill for school-based services using the schools as a separate site. And then in 2021, which we hope continues, Medicaid allowed us to bill for telemental health services, which made a tremendous difference. We were able to see thousands of children literally during the first summer of the pandemic who weren't in school and were shut out, and we were able to contact with them and work with them and make it work. Right now, what we're doing is supporting 132 of our 155 schools. I'm hoping that we can get to the whole 155 as we finish up this year. We have served 10,000 students this past year. 10,000 students out of the 77,000 enrolled, which is a great number of students. That doesn't mean we don't want to serve the other 67,000, but we're very happy to be able to do the 10,000. And then if we look at our model here, it's one of the models the Department of Pediatrics has been using. which the whole school, the whole child, the whole community, everybody integrating together with the idea that there is no silo, no one's off on this place by themselves. No one is pretending to say, well, I will do this if you just come to my office, or I'll do it if you just do it my way. We work on putting a way together where we can all do it our way. And our way is the Baltimore City way, where we all work together to make sure things happen for children. And we all, as the individuals in the program, have each other on our speed dials. Because you can't call people at night when you have a crisis, or you can't talk to people over the weekend when something is happening, then your program isn't worthwhile. Somewhere in there has to be an investment that says, we care about kids. That there is nothing more important than the kids. And if we have a little bit of a brush about who gets the more credit or who gets the less credit, the credit doesn't vary. We want the kids to get the service. Our funding for the current year is very interesting. Baltimore City Schools put $1.5 million into the program. Because one of the things that we were doing with Medicaid billing is Medicaid does not allow you to bill for early intervention and prevention. So we put that in so that our programs could bill for early intervention, prevention for students who did not have insurance, so that we could have them included in our groups and do all the things we wanted to do for them. That made a very big difference. We get money from a state block grant that comes through our behavioral health system in Baltimore, which is one of our partners. We got a grant because we applied for Project Aware this year, so we got another $200,000. We had a teen pregnancy grant, we added that in, and then the public behavioral health system. We got almost $500,000 from substance abuse prevention, and that was good. The rest of it comes from our ability to bill Medicaid. And the ability to bill Medicaid for treatment services, for group services, has made a tremendous difference. Currently, most of our students are Medicaid eligible. We do have some that are not. The other thing that happened is, in order to make a program work, you have to be able to show that it does something good. It's all very nice for us to sit here and say, oh, we're wonderful people, we're going to help all these students get what they want, we're good people. But the bottom line is, you have to make people think that your program is worthwhile. And I've listened to people talking about all these evaluation systems. Some of them are good, we use some of them are terrible because we can't show results for 3 or 4 years. But one of the things we did was we said, you know, this is a program that's designed for educators. We're an educational system. I'm an employee of the school system. What do educators care about? Do they care about their kids' mental health? Yeah, they do, but they care about student attendance. They care about whether students are suspended. They care about whether students are promoted to the next grade. So our first evaluation that we did was we looked at what the difference was between students who were in our program and students who were not in the program. So when you wanted to sell a program to a school principal, you could say, School X had this last year and 20% of their kids had improved attendance. 30% of their kids had improved achievement. So we've been looking at these kind of variables and saying, okay, those of us who are mental health people, and my doctorate is in psychology, I am a mental health person, but those of us who are mental health people, we believe that improved mental health is going to make an improvement in all these things that schools want. Schools need to know that what you're doing for student mental health is going to make them look better when they do their behavioral profile for the year, and the superintendent says to them, wow, your attendance is better. Wow, your kids are doing better on tests, and you reduced all your suspensions. You must be doing something right. And the answer is, yeah, you've got school mental health in the school. So that makes a tremendous difference. One of the things that did happen was there were some very nice, generous people out there who wanted to see what we were doing, and they gave us the money for a really deep in-person grant, which was done by Georgetown University. And they did a comprehensive program evaluation, which went beyond the simple things that we asked at first. But when they did that, they found that students had increased promotions, better attendance, fewer suspensions, and students not receiving services. And outside the district, we did a very intensive evaluation with a controlled study. And finally, in 2015, we did a reevaluation, and we found better attendance and fewer suspensions. One of the problem with quality evaluations is they're very expensive, and so we've been really cheap about not getting a lot of quality evaluations, but we are getting some evaluations. So we found that we did our evaluation for the 2021 that was done by Behavioral Health System Baltimore. We found that students with externalizing issues, substance abuse, externalizing substance abuse decreased, mental health risk decreased, internalizing, and these slides will be shared with you so you can look at it, but we found that everywhere, we found that even students with ADHD were doing better with getting our school mental health services. So that made us feel really good. We have a number of community partners. Catholic Charities, Hope Health System, Johns Hopkins Bayview, Time Incorporated, and University of Maryland Center for School Mental Health. Their partners are chosen through a request for proposal process. We conduct our RFP every 3 years. We always have a lot of people to bid. And our program components are class-based interventions, crisis support, family support, group interventions, and individual therapy. And we invite them to bid. We do not, it is not a place where you say how much you want to pay. We tell you what we're going to offer you, and you can decide whether you're going to accept it or not, knowing that you have the ability to bill the public Medicaid system. And RFP contains a menu of deliverables for a full-time clinician or a half-time clinician. It provides funding at $40,000 for a full-time clinician and $20,000 for a half-time clinician. Now don't shudder. My daughter, who's a major psychiatrist, looked at those numbers and said, "What are you talking about?" And said, "That's for the early intervention and prevention. Most of our clinicians are making close to $100,000, and that is working out. This is for the stuff that is not billable." We're still fighting with Medicaid about that because we think it would be a very good invention for them to make this stuff billable, but they haven't gotten there yet. Hopefully, we will win. The balance of the money that we need comes from fee-for-service, because if we don't have fee-for-service, we're going to lose it. One of the things that's happening to us, and I'm going to ask a hand raise here, we're getting an increasing number of students who are not insurable because of their immigrant status. Is that happening for all of you? And we're finding that that is making us more challenged in terms of getting our work done, but we are working on it. So we are going to get some significant new funding from the American Rescue Plan, and we're going to be adding 2 additional community partners for the 2022-2025 school years. We hope to meet our goal of having a community mental health partner in every school to meet the growing need. And as the program develops, it's become an integral part of the services provided in the schools, and the district and schools have set aside additional money to buy more clinician time. So the bottom line is, if we're going to give you a half-time clinician, and you look at your scores, your attendance is better, you're going to take a look at your budget and say, if I put this money in, it's going to be even better. I did it. A lot of people that have added their own money to this and have added all kinds of things that we're doing in schools. So we have a school that we're funding for a half-time clinician. They have a clinician and a half because the school has added, this is something that we really need. A lot of it is school choice, a lot of it is school belief, a lot of it is proven work ability, that this works for students, that it works for teachers, it works for anybody. So our belief is the school mental health services are a vital ingredient for successful schooling. Services in schools provide enhanced services for more students. Telemental health has increased the ability to serve students, and right now mental health services are more needed than ever. And those of you who have any kind of influence with the Medicaid things, don't let them discontinue the telemental health, because that makes a tremendous difference for students. And with the greater shortage of clinician that we're experiencing, certainly we want to make sure that we continue to be able to provide those services for children. If I sound like I'm on a soapbox, this is my favorite soapbox. Because there is nothing that we can do in school. Of course we're educating kids, but nothing we can do more than making our kids the valuable, productive members of society we hope they can be in the future. And mental health is something that they need. A sound mind and a sound body is what is needed by every kid to be successful. Thank you.
Thank you so much, Dr. Fink. That was a great, quick lesson in how to have community partnerships, a willingness to kind of grow together and add other people along the way in the service of supporting children. And next we have Lisa Hogan. She's a SHAPE specialist at the Minnesota Department of Education. She will be speaking today about innovations to support school mental health quality and funding in the state of Minnesota, and in her role as the State Mental Health Advisory Council in Minnesota.
Good afternoon. Thank you so much for having me today. I'm really thrilled to talk about what we're doing in Minnesota. In 2005, President Bush's push to transform mental health systems really was the impetus for MHAG, which is the Minnesota Mental Health Action Group. This is a coalition of consumers, advocacy groups, mental health professionals, mental health clinics, hospitals, health plans, state and local government, all working together to solve problems and make improvements in mental health services. They produced the roadmap to mental health, which led to the investment of the Minnesota legislature to appropriate general fund revenue to establish a school-linked mental health program to provide early identification and intervention for students with mental health needs and to build the capacity of schools to support students with mental health needs in the classroom. The state of Minnesota Department of Human Services issued a request for proposal, which was open to a competitive bidding process where community mental health providers and schools completed joint application. Community mental health agencies provide mental health professionals and practitioners at schools with most of their time involved in direct care, including assessment and treatment, as well as teacher consultation, care coordination, and school-wide training. Services funded by the School-Linked Mental Health Grants include identifying and diagnosing. I just realized I'm not doing my slides. My apologies. Thank you. Identifying and diagnosing mental health conditions of students, delivering mental health treatments and services to students and families via telemedicine, supporting families in meeting their child's needs, including navigating healthcare, juvenile justice, and social service systems, providing transportation to school-linked mental health services when school is not in session, building the capacity of schools to meet the needs of students with mental health concerns, including school staff development activities, and last, purchasing equipment and site fees in order to deliver telemedicine. As a condition of the grant, all grantees must obtain third-party billing reimbursement whenever possible. Grantees shall serve all of the students regardless of healthcare coverage or ability to pay. The foundation of the grant is a Medicaid benefit set, but the grant covers whatever Medicaid does not for the uninsured and underinsured, as well as ancillary expenses. So why in schools? As Louise talked about, we know that that's where the kids are. We know that schools are the primary mental health service providers for students with identified needs. Mental health challenges often emerge at school, and school-based services are often more accessible and less stigmatizing for students than other community mental health services. Research indicates that 60 to 80% of students who receive mental health services do so in schools. Last, youth are 6 times more likely to complete mental health treatment in schools than in other community settings. Some of the results of the grant include coordination of care with services delivered to where the students are at, increased access and sustained engagement in treatment, and evidence-based mental health services from highly trained professionals. This is just a slide that details the level of funding that started from 2008. We started with $4.7 million, and the second round of grants we went to $9.54 million, and this third round of grants we have $11 million annually with $15 million for fiscal year 22 and 23. These state infrastructure grants support school-linked mental health services through Minnesota. These school-connected clinical mental health treatments include interventions that increase accessibility for children and youth who are uninsured or underinsured. They improve clinical and functional outcomes for children and youth with a mental health diagnosis. They improve identification of mental health issues for children and youth. So, one of the things I wanted to talk about today would be just guidance if you were wanting to do something similar in your state. The first thing that is necessary is cross-agency collaboration. between the Department of Human Services and the Department of Education. It's critical to the success of the school-based behavioral health grants. There must be alignment of educational initiatives and behavioral health initiatives in order to best serve the students and to achieve positive results. Alignment with the multi-tiered systems of supports, or MTSS. Districts with the greatest success align their efforts with the multi-tiered system of supports. They have interventions at Tier 1, Tier 2, and Tier 3, which include the school-linked mental health grants. The partnership between the Department of Education and the Department of Human Services has been a new fangled thing in Minnesota. So it's a really good thing that we're finally working across agencies. We have to do a lot of educating and communicating about that partnership and about how we're working together for the needs of students. The first thing that you'll want to do is to develop a framework and then develop a service delivery model through resource mapping. I highly recommend you go to theshapesystem.com and look at their resource mapping tools that they have available. Louise talked about braided funding. We have to identify integrated funding barriers, and we need to braid funding when necessary. Data collection methods are another really important piece. One must develop the data collection methods. Start small, pick 3 to 5 things, and try to measure it really well. All of the schooling mental health programs have to do interventions that are evidence-based. Some of the most common interventions that are used in Minnesota are cognitive behavior intervention for trauma in schools, or CBITS, bounce back, and trauma-focused CBT. Lastly, the MDE, the Department of Education, and the Department of Human Services work together for an annual school mental health conference. We're planning our first in-person event in November. I'm really excited for it. We will have 3 tracks, one for clinicians with advanced clinical practice information, one for educators, and one for community members. With regard to challenges, workforce is definitely an issue, and we are working on some policy and language to develop alternative pathways to licensure. This is one of the big barriers that we are facing, and telehealth is definitely something that has been helpful and is very helpful in rural Minnesota. However, it brings its own set of challenges. I'm going to switch gears a little bit and talk about the State Mental Health Advisory Council. It was established in 1987 under the Minnesota statute within the Comprehensive Mental Health Act. The council is charged with making recommendations to the governor, the legislature, state departments on mental health programs and services. In addition, this group reviews the RFPs that are coming out of the Behavioral Health Division and provides feedback on the proposals. The governor appoints the State Advisory Council members, and members include individuals with lived experience, family members of individuals with lived experience, parents of children who experience emotional and behavioral disorders, and representatives of state departments, advocacy organizations, mental health professionals, legislators, county commissioners, social service agencies, and representatives with experience in the mental health system. The Children's Subcommittee was established in 1989 in order to make recommendations to the State Mental Health Advisory Council. The chair of the Advisory Council appoints the subcommittee members. Subcommittee members include parents of children with lived experience, former recipients of children's mental health services, and various representatives. There are 7 work groups that are charged with developing recommendations for the governor and legislature in their particular sphere of influence. I have them listed on this slide. The work groups develop formal recommendations every 2 years, along with letters of support for concern of various efforts. This year we did one for the closure of a psychiatric residential treatment facility, the development of 988 mental health crisis response lines, a position statement on conversion therapy, and a request for a declaration of the state of emergency for children's mental health. Last, I will talk about the Minnesota COIN. COIN stands for Collaborative and Improvement Innovation Network. COINs are a learning collaborative that bring together multidisciplinary teams of federal, state, and local school leaders in partnership with subject matter experts to address a specific complex challenge. COINs use an innovative, multifaceted learning framework to rapidly translate knowledge into best practice and practical program change. In 2019, Minnesota joined the School Health Services National Quality Initiative that's led by the National Center for School Mental Health and the School-Based Health Alliance. The mission of the National Quality Initiative is to challenge comprehensive school-based health centers and school mental health systems to adopt, report, and improve standardized measures. Generally, COINs seek to use experience and skills of all participating partners to speed the transfer of research-informed knowledge by fostering implementation and improving quality of school mental health across states and districts. COIN participants test, implement, refine, and scale up innovative improvements to school mental health quality and sustainability through learning cycles. The learning cycles involve a virtual learning session every month, technical assistance and coaching, selection and implementation of change packages, utilization of data systems for reporting, and quality improvement. As part of the National Center for School Mental Health's COIN work, Minnesota established a COIN team to advance policy and practice in school mental health. In the 2021 academic year, we were a part of the second year of the COIN with the National Center for School Mental Health. And in 21-22, Minnesota developed its own COIN. So we're supporting 17 districts locally across the state of Minnesota, and we are experiencing great success. Some of the examples include a development of a district-wide student triage form, development of an after-school homework help program, implementation of an elementary screening tool, and completion of the state mental health profile and next steps for policy work. Quality improvement is achieved by receiving expert technical assistance and coaching, exchanging best practices and lessons learned with other teams, and tracking progress towards key benchmarks and improvement goals. Quality improvement and innovations are tested monthly at the school sites using the Plan, Do, Study, Act cycle, and they are intended to inform policies, procedures, programs that promote quality, sustainability, and growth. I apologize, I am behind on my... The aims of the COIN are to leverage the collective knowledge and innovation of all the teams, to ramp up the application of best practices, to test, implement, scale up, and sustain comprehensive school mental health systems. Minnesota has leveraged cross-agency collaboration for the COIN by having staff from the Department of Health Suicide Prevention Unit, the Department of Human Services, the Department of Education, and the Midwest Center for School Mental Health. We will be opening our application for the 4th cohort later this month, and we hope to engage another 21 districts across the state of Minnesota. Thank you.
Thank you so much, Ms. Hogan. And hearing about all the great work that's happening in Minnesota is awesome, and I appreciate the plug for the shape system. See my little dance? I forgot I wasn't behind the screen anymore. Next, we have Angela Kimball. She's the Senior Vice President for the Advocacy and Policy at Inseparable, a mental health advocacy organization. She will be speaking today about policy opportunities for the state to support school-based behavioral health services.
Welcome everyone. It's wonderful to be here, and particularly lovely to come after Louise and Lisa. Hearing their stories of what they're doing in their school systems and states is fabulous. It's just very inspiring. I'll just share that Inseparable was formed in 2020, and it's a growing movement of people across the country who are dedicated to promoting policy solutions that reflect the belief that the health of our minds cannot be separate from the health of our bodies. We're focused on 3 policy areas: closing the mental health treatment gap, expanding crisis response, and ensuring that every student has access to the mental health care that they need. And as part of that, last year, Inseparable launched the Hopeful Futures campaign. And you'll see that we did this with the help of 16 partner organizations, more coming on board every day, and they span a wide spectrum of interests and perspectives, which is an important element here. Our Hopeful Futures campaign partners know that there's a youth mental health crisis in our country, as do all of you, and all are committed to bringing mental health services to every school in the country so that every child has the opportunity to thrive. And to do this, we launched in February of this year a first ever report card that rates states on state level policies that support comprehensive school mental health systems. We wanted to create something that supported both measurement and action. We didn't focus on wonderful programs like we've heard today that are implemented by individual schools or districts or often with federal grants. Instead, we focused on what state policymakers are doing to support scaling school mental health across the state. And to do that, we focused on 8 policy areas that we describe in more detail in our report, and we have a scoring guide that explains our criteria. But here are the 8 categories. School mental health professionals. Obviously, they're key to delivering services. School family community partnerships, which you've heard so much about today. And in fact, we highlight Minnesota, which is well regarded for its school-linked mental health services. Teacher training, funding supports, well-being checks, which is our way of saying mental health screenings, healthy school climate, which actually encompasses a number of different policy areas for us, everything from anti-bullying policies, school climate surveys, inclusive environment policies, mental health excused absences, alternatives to exclusionary discipline, and suicide prevention programs. Mental health education, and something we call skills for life success. I'll talk a little bit more about that later, but the shorthand is social emotional learning, which is a more commonly used term. It reflects skills, competencies like responsible decision making, relationship skills, self-management. So this slide shows what these categories look like in full for a particular state. In this case, Alabama, I believe. So we identify for each state in each of those 8 categories policy that has been enacted in that state with links to the data sources, our rating, and then policy recommendations geared towards state legislators. And this is just a glance at our tables that show ratios of school mental health professionals in rank order. Now, this is just another way of presenting the data. We have this for every state, but here in each of these pages show how each state stacks up compared to others. We also include a section called Policy Pace Setters, and it doesn't capture all the great work that's being done in every category, but it does give a flavor of the work that's going on and shows that good policy is being enacted all across the country in red states and blue states. For example, Maryland requires restorative approaches to discipline. It analyzes the data they have and makes plans to address disproportionate impacts on minority students and students who are in special education. New York, Virginia, Florida have passed landmark mental health education laws, and actually those have been adopted now by a number of other states across the country. Michigan has expanded its Medicaid program, as a lot of states here have, but not all, to cover school mental health services. One thing that's notable about Michigan is they made sure to include school-based mental health professionals as professionals who can actually bill Medicaid. So there's two parts to this: covering school-based mental health services and then covering the professionals that are providing those services. Michigan also created a school mental health programs advisory council. We know Minnesota, Kansas, many other states have this as well. North Dakota, an interesting state, requires 8 hours of behavioral health training every 2 years for teachers. So these are wonderful little examples, and we just use them as tidbits, and frankly, we're using these data points with legislators across the country to show them that there's good policy that can be enacted anywhere in this country. And just to help folks along, we did a Harris Poll survey in February and conducted with thousands of adults in this country. And what was really wonderful about the results that we got, school mental health and youth mental health in general is a bipartisan issue. 87% of Republicans and independents are concerned about the mental health status of youth in this country, and 88% of Democrats. Across every demographics piece that you could think of, really remarkable unanimity of support for school mental health. 87% are concerned about the status of mental health in our youth, and the vast majority, well over 80%, support individual school mental health proposals, things like adding more school mental health professionals into school buildings and supporting partnerships between schools and outside school mental health providers and providing things like that social and emotional learning. In addition to this kind of polling, which helps lawmakers really understand that they are not going out on a limb, they are doing what America wants when they work to advance school mental health. We also created an action center on our website that allows anyone to call, post, write, sign a petition for their specific state supporting school mental health services. And then here's the piece that I really love. Once we launched this report card and we mailed it to legislators in every state in the country, we went to work in 5 target states and we began tracking school mental health bills across the country. And we did something that I consider to be highly important and very effective. We hired really good lobbyists in 4 out of those 5 states. We're also partnering with grassroots activists and organizations like NAMI Delaware. And just a few weeks ago in Illinois, HB 4343 passed. It creates a $5 million appropriation for a well-being check, read mental health screening program for grades 7 through 12. There's also some additional money tucked away in the Medicaid budget to help support that. More on that. Alabama. HB 123, Mental Health Services Coordinator in every school district, $5 million appropriation. That bill was close to being dead, got it resurrected, and it passed recently. Right now in Alaska, mental health education bill is in the works. Delaware, right close by. We actually have 3 bills going. HB 301, which is a mental health education bill, HB 300, which would increase ratios of school mental health professionals in middle schools, and a piece that would cover behavioral health annual checks, or require that all health insurance plans cover annual behavioral health checks for anybody covered by insurance, including at school-based health clinics. So these are some of the things that we're doing in states, and it's really very exciting because legislators, frankly, want to do something to help kids. What they need is some guidance in how to do it and what's already been done. Really, the answers are out there, and the important thing is get them to support bills, pass them, allocate funds. And we do this because this kind of great work that you've heard about today requires sustainable funding. And that means the commitment of lawmakers to add those funds to their budgets on a regular basis, especially at the state level, because those state general funds provide a lot more flexibility than a lot of other funds. I also want to mention that we're working at the federal level. We're doing a couple things. One, the federal government has the ability to actually print money and infuse systems with far more money than states can do because they're not required to have a balanced budget. So we're trying to get additional money for school-based mental health professionals and for programs like Project Aware that many of you have worked with throughout the country and funded at a much higher level. But another piece that we're working on is we've worked very closely with the administration to let them understand that the current guidance for billing Medicaid for school-based mental health services is antiquated, over 20 years old, and it creates enormous barriers for school districts and Medicaid programs to really put forth programs that are effective and efficient. And fortunately, this administration made a commitment to update that Medicaid guidance. So we're looking forward to that because that's another key piece. We need the federal government to get out of the way of people who are doing great work. So in short, we really have a winning combination, we think. We have a strong coalition. We have a state-by-state report card with policy solutions, and we have a campaign-style strategy that we're implementing in target states and with Congress and the administration. And it's all focused on advancing state school mental health policy and federal. Thank you.
Thank you so much, Ms. Kimball. It was great to hear what's happening at the state and federal level, and I appreciate all of our presenters sharing all the great work that is happening at all the different levels, and it gives me encouragement of the different ways that we all can get involved and move the work forward. It seems to be tons of avenues for making this better services for our kiddos. So now I get the fun job of being able to ask some questions, and then we'll have time too for audience members to ask questions as well. So the first question I have for the group is, based on your experiences, how do we increase buy-in and gain support of parents, healthcare workers, legislators to support funding for comprehensive school mental health?
By showing them that it works. In other words, if you have, you need your pilot programs everywhere that will show that students who are receiving mental health services are doing better in school. And it's very important to not give in to the idea that we're going to show them that they're better off in terms of mental health, because the schools will say they need to use their funding for educational purposes. But if we can convince the schools that the mental health improvement is going to give them better results in what they're accountable for, that works. The other thing about it is, and this is my opinion, and everybody may not share it, is sometimes you have to begin small. You have to have a demonstration project that you can show your legislatures, this worked. And this worked for this school, and this worked for that school, instead of going into the whole great big thing at once.
What we found in Minnesota is the alignment between the Department of Education and the Department of Human Services has been critical to the success of these programs. We know that schools have a ton going on already, and so we need to meet them where they're at. In terms of using the multi-tiered systems of supports, we believe that aligning the educational initiatives and the behavioral health care initiatives is critical to the success of the programs.
Thank you so much for that. Did you want to add? That actually leads right into my next question. What do you see as the role of research in supporting the future of school mental health? As a researcher myself, I'm always interested in hearing about ways that we can support schools and districts in their improving their school mental health services.
Well, what I was talking about originally was research, but there's a lot of different kinds of research. Some research is better than others for proving results. the result that works the best with schools is outcome research that says this is what happens when you do what we suggest. The other research is the longitudinal research, which will tell you what happened over a long period of time. That's more impressive for legislators very often. But for example, one of the things that I found most puzzling about research when I was early in my career was the research about Head Start that showed that when you got into third grade, there was not a lot of difference between the kids who'd been in Head Start and the ones who hadn't. But when they did the longitudinal research years later, they showed that the long-term effect of having been in Head Start before you started into your regular school programs carried on all the way into the fact where you were more likely to finish high school and more likely to do well. So you really need both. But the convincer at the beginning is really the outcomes research that says, this is what you get if you do it.
State agencies aren't known for their research, so we rely upon your research to inform our practice and to develop all of the evidence-based programs that you help us to choose from in order to get a successful initiative.
I would say a couple of things. Research gives lawmakers cover to do the right thing. It gives them data points to use. The other piece about research is it gives us information that allows us to start at the same place with each other. So one of the things we've learned from National Institutes of Mental Health, half of all lifetime mental health conditions begin by age 14, 75% by age 24. We also know from their research that the average treatment delay is years, if not decades, before people get help. And we also know from them that the longer you take to get treatment, the harder, more complex conditions are to treat. We also know the converse is that when you intervene early, you can get better outcomes, lower costs, less severe conditions. Those are powerful tools in talking with lawmakers. They need to hear that we are all paying the price of not intervening early and letting people suffer and have more severe conditions that are often compounded with substance use and co-occurring medical conditions. So I think too, when I think about our audience, which has so many people from the healthcare sector, you're seeing people with mental health conditions every single day. The earlier we can get people the mental health care they need, it's not only better school outcomes, academic outcomes, better health outcomes when we intervene early. And research is part of what shows us that.
Thank you so much. I have a follow-up question. I know in Baltimore we have a great relationship with the city schools, and I also know that sometimes it can be difficult to form research and practice relationships. In any of your experiences, have you had success with creating those partnerships or things that have helped you kind of bring that relationship to the buildings and to the schools in a helpful way?
We've been gifted with wonderful people at the University of Maryland, so you can't always create them. So, but the people there are people who've been very interested in children. One of the things that is very hard to document in terms of research, I'm still trying to figure out how to do it, is this concept of early intervention and prevention. Some of the money that we have in our grant is on the early intervention and prevention. We're trying to work on ways to figure out how to access research on early intervention and prevention because it's something that doesn't happen. But we believe that a public health model for mental health is something that is really important and significant in working with children. We don't wait to figure out how many kids get polio so we can treat it. We do immunizations. And there's a lot of things that we do, whether it's COVID immunizations, whether it's immunizations for other diseases, that we do on a regular basis. We do substance abuse prevention, and then we need to be doing early on groups. Social emotional learning and groups like that with students who are pre-K, K, first grade, second grade, so that we don't get to the point where they've developed that mental health need.
So you asked about partnerships. Well, I'm not working at the school level or school district level, but I would say in terms of policy, it's always about relationships and partnerships. And the key to that is always finding shared interests. Really. And Louise said something so potent earlier, and that is start small. So even if you only agree on one thing, start there. If you can agree to start small, start there. I mean, we certainly see that with Congress, and are always trying to look for the pathway forward that's going to actually bring people together and not pull them apart.
I love that reminder. It can be hard to remember to start small, especially with all the things that schools have to take on. And so to start small can make change is also a great reminder. And some of you spoke to this during your presentations, but I'm curious on how do you think state and district leaders can really help support the work that's happening on the ground in school buildings?
Bed. One of the things that always helps, and this sounds very redundant, is letting them know that what you're asking for is something that's for their children, their grandchildren. They all have people who are attending schools. Public school education is one of the hallmarks of our great democracy, and that things that can make it work better, things that can make kids do better, are really important. And you have to sell it on the basis of these are things that we're doing for children. One of the things that we had mentioned earlier was people don't always do things that are best for children because children don't vote. Remind them that they will be the voters of the future, and that they are the people who are going to maintain everything, and that what happens for them is the most important thing we can do.
I'd just like to make one more plug for the shapesystem.com. It's out of the National Center for School Mental Health, and it helps districts and states really look at the policy work, look at the evidence-based programs, and work to find the most successful options in school mental health.
And during your presentations, you all spoke to this in a way of like being really good advocates around school mental health and for policy change. Do you have any recommendations for folks in the audience on how to take on advocacy challenges or be a good advocate in this space?
Hours of advice. but I would say, really, let lawmakers be heroes. Everybody wants to be a hero, right? So, frankly, I don't want anybody to hear this. I say it's almost like working with children. It's give them healthy choices. So I've actually found that lawmakers, they want to do the right thing when you lay out the problem very simply, but give them strong solutions that work, that have been successful elsewhere. Give them choices and let them paint that pathway forward, and then say, we got you. We'll have your back. We will do the social media, we'll do letters of support, we'll testify, we'll make sure this goes through. That's what legislators really want. They want to know you've got their back, not having you come and beg for something. Make it their idea, make them the hero, and then do everything you can to support them in that.
I think change starts with each of us. And as a parent on the State Mental Health Advisory Council, I've learned a lot about the policymaking agenda. And I think that it's up to each of us to work with our legislators and be that voice for the children and really work to push the policies through.
And I'll just add, because I think you're got a session on youth voice right now in another area. Youth voices, family voices, so important because the stories of people who are actually living are just incredible. And I just know that when I was listening to the Senate Health Committee hearing earlier this spring, a young woman from the state of Alaska shared such a poignant story of her challenges with mental health while she was in school, and how she didn't have anyone to turn to, and she had no place to go for information except for the internet, and it took her down some very dark places. So powerful, so moving, actually moved one of the senators to cry, and those things make an impact. We now have bipartisan bills that are moving forward, and I do believe it is the power of story that is so important in all of that.
Those are great recommendations. We gotta get the origin story for all of our legislators to be Batmans of their fields. And in your experience as well, in working in all these coalitions and building your programs across your states and your districts, have you found any like key ingredients to working together that have helped them along, or things to avoid for us as well?
There was an expression that was used early on when schools were beginning to put some programs in there, and the warning was that don't walk into a school building like the sage on the stage, that you know everything and you can fix everything. Make it collaborative, make it partnership, make it things that you can do together, so that together we're going to create something that's going to work. Together we're going to build something. One of the things that I have found, and remember I'm working in the microcosm of a district as opposed to a whole state or a whole country, is that if you find a school with a strong principal who wants to work with you, you can do a really good demonstration project at the beginning. Because if you find a principal who's committed to making change and a principal who's committed to working with you, that makes the difference, and then you have your demonstration project.
The whole PolicyLab is about partnerships, and I can't say enough about having cross-agency collaboration to really work towards advancing comprehensive school mental health.